Okay, good. We're still in the morning, I believe. Good morning, everyone. Thank you so much for inviting me um, to share what we've been able to accomplish at Memorial Sloan Kettering Cancer Center's Josie Robertson Surgery Center regarding standardizing opioid prescriptions after ambulatory oncologic surgery. Um, my name is Nkechi J Fearon. Many people call me Nikki. It's a little bit easier to pronounce. And like the introduction stated, I do work at Josie, and Josie is a freestanding surgical facility that opened in the Upper East Side of New York City. Um, we opened in 2016. We have 12 operating rooms that are specifically designed for our short stay procedures. And these procedures are categorized into two different tiers. One is the outpatients, and these patients have surgery and they're discharged the day of surgery after their recovery. And then we have another group of patients that we consider ambulatory extended recovery, or AXR patients, and these patients will stay overnight. We do have 28 private rooms with bathrooms and caregiver spaces for our patients staying overnight. And just a quick touch base on our mission and vision here at Josie. We really want to be the best that we can be in what we do regarding our short stay and ambulatory facility. Yes, we look at efficiency and cost effectiveness, but our goal is really to optimize and maximize our clinical quality and safety, have unmatched patient experience, our focus on continuous improvement through innovation, collaboration, and really providing an environment that is safe and congruent with recovery for our ambulatory patients. So in the 6 years that we've been open, we've had a total of just shy of 47,500 cases. The majority of these cases are outpatients. About 65% of these cases are patients that have surgery and go home the same day. The other 35 are ambulatory extended recovery patients. We also do perform robot-assisted cases. This is about 14% of our cases. However, the majority of our procedures that patients undergo at our facility are breast surgery cases. And as you can see, there's quite a bit of different services with different procedures that take place at Josie. Procedures that do occur here at our center include our simple mastectomies, our lumpectomies, the total mastectomies, with and without immediate breast reconstruction. We do perform robot and laparoscopic radical prostatectomies, partial nephrectomies, and hysterectomies. Our unilateral or total thyroidectomies, partial parotidectomies, are plastics cases. For example, our breast revisions, reductions in lips, melanoma excisions. We do have patients that come to the facility for a few hours for spinal cord stimulator or ketamine infusions for pain management. Dental extractions, and we also have ophthalmology procedures like our eyelid surgeries. So a little background is, the United States is in the midst of an opioid epidemic, and although there was a plateauing starting in January 2018 to about 2020 of deaths, overdose deaths from opioids, we've started to see another incline here, and it really kind of started, I would say, with the COVID pandemic. And unfortunately, we are seeing more deaths from prescription opioids. Sadly, from 1999 to 2000, deaths from overdose of prescription opioids increased almost fivefold. And specifically in 2020, about 75% of all drug overdose deaths was attributed was involved in an opioid overdose. So in light of all that, in about 2018, we sat down a couple of years after we opened at Josie, and we really wanted to know what we were prescribing for pain, this being opioids or non-opioids, and how much our patients were requiring to adequately manage their acute post-operative pain. So we devised a plan, we took it to our IRB, and we initiated this quality improvement initiative. with the primary aims of identifying the number of opioids that were prescribed, the number of opioids that patients were using after discharge, including any refills that were obtained. Secondarily, we were looking to identify the opioids and non-opioids that we were discharging our patients home with and determining pain control with these medications. And we were really also hoping that we could facilitate modification of a standard discharge opioid prescribing practices that were in place at the time. So we basically decided to have two groups. We had a cohort with in the pre-standardization phase, which is where nothing was done. This is a phase where we just wanted to see where we were. And then we had a phase of post-standardization cohort that if we implemented changes, we would want to go back and look at and see the impact of the changes. Now, we looked at the different surgical services between 2018 and 2019, and our sample patients were consecutive opioid naive patients who were 18 years or greater. Those patients had underwent robotic or laparoscopic hysterectomy, radical prostatectomy, partial nephrectomy, as well as total mastectomies with or without immediate breast reconstruction. We created a telephone survey, and patients received a call 7 to 10 days after hospital discharge. And this is where we were able to accrue the data on patient-reported opioid use for postoperative pain. We were able to go into our patient's e-medical record to determine the type of opioid that the patient's opioid and non-opioid that the patient was discharged home with, along with any refills that were obtained. So in the after pre-standardization phase was completed, we realized that one, we had variations in the amount of opioids that we were prescribing within the same services and among the different services. And we also realized that we really were overprescribing our opioids for postoperative pain. The teams all got together, decided to reduce and standardize the opioid prescriptions to meet approximately 80% of patients' opioid requirements. And we chose 80% of the 80% because looking at our literature reviews and other listening to other organizations that had done similar studies or a quality improvement project, that was a benchmark percent rate. So we started the survey process all over again. And we had quite a good representation of patients. We had overall a potential of about a little under 1,200 patients that were eligible, but we had a response rate, which was 86% response rate, which is a little over 1,000 patients. We did have to exclude certain patients, and we excluded patients from this initiative if they were transferred after discharge or sometime after surgery for any medical or surgical issue. Patients were also excluded if they were admitted soon after discharge from the center. Patients who were being treated for chronic pain were obviously not a part of this study because many of our chronic pain patients, they have their own regimen, and we did not want to disrupt that. We did exclude one patient because he did disclose that he was abusing opioids at the time of his surgical procedure. We also excluded patients who declined the survey or we were unable to contact after 3 phone calls. And we had 8 patients who we excluded because they were not discharged home with any opioids at all. And we do have some patients that come in to have surgery, and they tell you whether it's their preference or their personal history of substance abuse that they do not like. They don't want any scripts, opioid scripts, and we basically adhere to that request. So our opioid prescriptions per surgical service for all the surgical services except for the breast service, Norco, the hydrocodone 5 milligrams with acetaminophen mix, was our standard opioid prescription. For the breast surgery patients, oxycodone was a standard opioid prescription, the 5 milligram dosage. We did have outlier patients that did receive the other opioids, for example, the hydromorphone, the Percocet, tramadol, and codeine, and they received these medications if they had an adverse or allergic reaction to other medications that were our standard, or they just did not receive any good pain relief postoperatively, so we had to switch their regimen. We also sent our patients home with non-opioid prescriptions, plain Tylenol, diclofenac, and ibuprofen are NSAIDs of choice. And as you can see here, the majority of our patients did use these medications. Certain surgeries, surgical services, for example, the GYN service, gynecology service, took less Tylenol, but if you look below, they use more of the ibuprofen, possibly for those anti-inflammatory properties there. For our breast patients that underwent total mastectomies with immediate reconstruction, we do send them home with a benzodiazepine, and that is lorazepam, and they will receive the benzodiazepine if one, they received it while they were admitted. So if they did not receive it at all, they did not require it while they were admitted, they don't go home with it. We also don't send any patients home with any additional benzodiazepine, the lorazepam, if they actually had an order, an active script for a benzodiazepine. And we order this simply because it's been shown to loosen up some of that chest wall musculature after the immediate reconstructive part of the surgery. We do send our patients home with 21 tablets. It's 0.5 milligrams of lorazepam every 8 hours. As you can see here, that the median number consumed is 7 to 8 pre and post operatively, and we're actually looking to see if we can change that a little bit. So pre-standardization, as you can see here, we had a sample size of 551 patients across all the surgical services here, and anywhere from 31 to 49% of our patients took no opioids at all. So we had all those excess opioids that were sitting out there. More specifically, during this pre-standardization phase, we noted that the median amount of pills that were prescribed for the urology, gynecology, and breast service was 20 pills. The median pills that were taken was less than 5, so anywhere from 1 to 3 pills were taken, and the percentage of patients who received a refill was anywhere from 6 to about 12%. Post-standardization, when we made our changes, we had a size of 480 patients, and during this cohort, our urology service had decided to prescribe 8 tablets of the hydrocodone acetaminophen, the narco. Gynecology decided to send our patients home with 7 tablets of narco, and the breast surgery had opted to send the patients home with 10 tablets of the oxycodone 5 milligram strength. As you can see, the median amount of pills that were taken, although it was slightly increased, it was still under 5 pills. We did have an increase in the percentage of patients who received a refill. Across the board, it went from 4.4 to 7.2%, with the largest increase in our breast patients that had, our patients that had total mastectomies with immediate reconstruction. This was an increase of 14.2% increase. And, it was an increase that, we noted. However, in the grand scheme of things, and we didn't, and in, with the epidemic, we didn't think that it was prudent for us to increase what we were sending our breast patients home with. We have, right now, this is our standard here at Josie for the most part. Our clinic nurses and our clinic team, as well as our patients, are not coming back and saying that, we really needed a refill, our pain was inadequately maintained. And we really found that pre-op patient education played a huge role in letting patients know the expectations, what to expect after surgery regarding pain, as well as the pain medication regimen. We were fortunate enough to publish our findings in the Joint Commission Journal on Quality and Patient Safety in 2020. But like I said earlier in the presentation, we are a facility that is always looking at continuous improvement, and our data really showed that there was some room to further reduce our opioid prescriptions. And we decided to do a lit review, and we found that there were 2 other organizations that had imposed ultra restrictive opioid prescribing practices and were successful at that. And since we were successful in decreasing our our opioid prescriptions in general, we felt that we could do this as well. And we decided to start with our urology population. So our baseline results, we had about 175 total patients. And this is, at the time, these patients were going home with 8 opioid pills, predominantly the narco pills. We had a great response rate of 85%. This survey, though, that was sent out electronically through our patient portal, it was not a phone survey like the previous survey. And what we found was pretty eye-opening that only 7.4% of our patients took more than 4 opioid pills after discharge. So here we're seeing that we still have some excess pills that are out there. 4 patients received refills. And this is just a quick view here. Once again, 62% of our patients did not take any opioids at all. So we decided that we were going to implement an ultra-restrictive protocol, and it was basically the same as the previous protocol, but in reference to our opioids. If patients would only receive an opioid script after they had their urology surgery, if they received 2 or more opioid pills while they were admitted. This did not include any IV pain medications that they received. It was strictly about the opioid pill use. We gathered the data, put it all together, and we found that less pills were dispensed and more patients did not take not even one opioid pill. So 72% of our patients didn't take any opioids whatsoever. So right now we've actually left it at 4 tablets for our urology patients. And we've actually across the board here at Josie decreased opioid prescriptions in our head and neck population and the other some of our outpatient plastics services as well. So just a quick view here. You can see that our previous opioid script of 8 tablets versus our ultra-restrictive opioid script when patients are sent home with 0 or 4 pills, we had a substantial decrease in the amount of pills that were prescribed, the amount of pills that were taken, excess pills that were available out there in family homes and communities for diversion, misuse, and abuse. And we also substantially decreased the amount of opioid refills that were dispensed. So to conclude, we realized that a comprehensive survey of patients' postoperative pain medication use really enabled us to establish a standardized opioid prescribing policy that significantly reduced the number of opiates that we were prescribing without impacting pain control or significant prescription refills. However, we do believe that continued research, patient education, and provider training is important in maintaining and establishing these evidence-based guidelines. We really do need more of these studies and initiatives out there to look at various different types of surgeries, because although there's more information coming out now, we still have some work to do, and we all should continue playing an important role in, addressing this opioid epidemic. It's not about withholding medications for pain. It's about sending our patients home with the right amount of medications, and looking at not just opioids, but non-opioids and other alternative methods that we can use to adequately address acute postoperative pain. Thank you. Any questions?